Good afternoon and welcome to the Family and Community Medicine Grand Round Series. Today, we are delighted to welcome three presenters who will be speaking about expanding on alcohol harm reduction, the San Francisco Department of Public Health Managed Alcohol Program. But before we begin, I wanted to introduce myself. My name is Dr. Megan Mahoney. I'm filling in for Dr. Margot Venner today, who is unable to attend today's session. Just as a reminder, our session is being recorded, and I do encourage you to use the Q&A tab for your questions and comments. And also, I want you to know that you can view this Grand Rounds or any prior presentation on our website. I also wanted to acknowledge our tech team today, Dorothy Wang, Arrigo Mitchell, and Roy Johnston. I will introduce the session and our presenters today. The San Francisco Department of Public Health's Managed Alcohol Program, or MAP, started in 2020 as a COVID isolation and quarantine response for people who drink alcohol, but has become a permanent part of the city's harm reduction services. During their presentation, the presenters will discuss how their MAP program began, define the scope and purpose of MAPs, describe the different MAP care models in the literature, and identify key ethical issues at play in alcohol harm reduction work. Alice Moughamian serves as a nurse manager of the Managed Alcohol Program and the San Francisco Sobering Center for the San Francisco Department of Public Health. In addition to this role, she was nurse manager and program director of the Medical Respite Program, as well as nursing services in permanent supporting housing before devoting full-time to the Managed Alcohol and Sobering Program. She completed the CHCF Healthcare Leadership Fellowship in 2020. She also served as chair of the National Healthcare for the Homeless Council's Respite Care Providers Network and helped develop national standards for medical respite care. She worked as a floor nurse at UCSF Medical Center for 4 years and did her clinical studies for her master's degree at Zuckerberg San Francisco General Hospital's Positive Health Program. Alice served as a Peace Corps volunteer in the Dominican Republic for 3 years between college and nursing school. When not working, Alice's greatest joy is going on new adventures and spending time with her husband and her 2 children. Bryce Bridge is a licensed marriage and family therapist and clinical supervisor for Sobering Center Case Management, which is a low barrier intensive care management program for people who use alcohol. Bryce obtained his master's degree in clinical psychology from San Francisco State and is a licensed marriage and family therapist. Bryce was working in community health, mental health, and substance treatment with marginalized populations throughout the past decade and has been employed at UCSF Citywide Sobering Center Case Management since 2019. Tanya Majumdar, MD, is the lead physician of the Managed Alcohol Program and the Sobering Center, and is also a primary care physician with street medicine, shelter health, and urgent care. She completed medical school and her master's in health and medical sciences at the joint medical program between Berkeley and UCSF before attending residency in an internal medicine primary care program at Yale. She has greatly enjoyed being part of the whole person integrated care team for the last 4 years. Welcome, Alice, Bryce, and Tanya.
Thank you so much, Megan, and thank you everyone. Good afternoon. We are super excited to be here today, and we are really excited to discuss our managed alcohol program and really learn with you and teach you about this new modality of care that is currently emerging. As Megan said, I'm Alice Moughamian. For the past 14 years, I've been nurse manager of the San Francisco Department of Public Health's Medical Respite Program and Sobering Center. As you will hear in this presentation, we are currently building this new novel managed alcohol program. And as such, after it's a bittersweet, but I've been moving away from the respite program to dedicate full time to launching managed alcohol. I will be going over the first part of our presentation today, and I'm delighted to be here with Bryce and Tanya. It is our hope that at the end of this presentation, you will understand what exactly is a managed alcohol program. We also hope that you will appreciate our harm reduction-based philosophical approach and to understand the tremendous impacts that this type of program can have for individuals as well as the healthcare system, even when we struggle every day with interplay between harm reduction and patient autonomy. Before we get started, I do need to give you a little history lesson. San Francisco has long had an alcohol sobering center. In fact, this year marks the 20th anniversary of the Sobering Center. For all of these years, the Sobering Center has provided a place where people who are acutely intoxicated on alcohol can come to safely sober outside of the jails, off the streets, and outside of the emergency departments. Clients are referred by EMS, police, fire, street outreach teams, and emergency departments once they are medically cleared and still acutely intoxicated. In the Sobering Center, clients are clinically monitored by registered nurses, and our highest utilizers of the Sobering Center receive care coordination and intensive case management from on-site social workers such as Bryce, who is here with me today. And we are doing this in the Sobering Center at the place and at the point where our clients are touching the system the most, right there in the Sobering Center. To give you an idea, the Sobering Center has 12 beds, and in the fiscal year 18-19 prior to the pandemic, we saw an upwards of 5,000 visits in our 12-bed Sobering Center. In May of 2020, we had a COVID outbreak, which led to 25 clients being exposed to COVID, many of whom were our highest utilizers of the Sobering Center, and many of them spending an average of 5 nights a week there. These were clients with severe alcohol use disorder that would be at high risk of withdrawal. And while our traditional isolation and quarantine sites that we were developing the Department of Public Health were developing at that time, our clients had such severe alcohol use disorders that they could actually not be served in the traditional I&Q or isolation and quarantine sites. At that point, we had to decide how we were going to support these 25 individuals. And in that moment, we decided to close sobering, move our entire staff over to isolation and quarantine, and set up a managed alcohol program. We had about 48 hours at that time to get our nurses station set up, get our clinical protocols managed, our clinical protocols for managed alcohol written, and then moved into the new site. And that really is how managed alcohol was born. During those early days, while we were working with our EMS 6 partners to find our exposed clients, during those early days, we worked with EMS 6 to find our exposed clients and then brought them into isolation and quarantine and started this process of managed alcohol. What we learned was that by giving clients a motel room, 3 meals a day, and dosing them with enough alcohol to meet their addiction needs, but keeping someone at a safe level of intoxication, we saw a marked difference in our clients just in those first 9 days. These were clients we knew really, really well from night after night in sobering. We saw clients not only achieve levels of stability we never thought possible, we also saw a marked decrease in EMS and emergency department utilization. As we move past that initial isolation and quarantine period and on in the pandemic, the goal of MAP actually morphed, and it was shifted from an emergency isolation and quarantine response to trying to reduce emergency department and acute care utilization among those with severe alcohol use disorder. We now have a long-term program. We are building a program to support 20 beds, with 10 of those beds earmarked for the Latinx and Indigenous population, while still supporting our 12-bed traditional sobering center. I have to admit that prior to the COVID-19 pandemic and the initiation of the MAP program as a COVID response initiative, I knew next to nothing about the concept of managed alcohol, despite working with the Alcohol Sobering Center. This is in part because managed alcohol programs, especially formal clinician-driven models, such as the one we'll be discussing today, are not common in the United States. This approach has been widely used in Canada and in a number of European countries for some time, but we in the United States have not quite gotten the buy-in that we would love to have to be able to make this a more mainstream type of program. Managed alcohol exists as part of the continuum of alcohol use-related harm reduction strategies, both abstinence-based and non-abstinence-based, ranging from residential treatment to sober living environments to moderation management and alcohol sobering centers. Before describing our program in detail, it's really important to address a major driver of our work, which is how we think about this philosophically. We get asked this question a lot. Our goal at MAP is not to decrease the amount of alcohol that is consumed or to taper someone towards abstinence, although both of those things have happened with clients in our program. The goal is to mitigate the many health, legal, and interpersonal harms associated with unsafe alcohol use. From a system perspective, we aim to decrease EMS, ED, and acute care utilizations acute care utilization from falls, physical injuries, and alcohol withdrawal, in addition to decreasing engagement with the clinical justice system. What this looks like for our clients, however, is that MAP focuses on improving clients' sense of safety, security, dignity, and overall quality of life. As we know, there are many existing treatment models for people interested in abstinence, but in MAP, we believe that clients do not have to be abstinent to connect to care, feel safe, and have dignity. I want to acknowledge that this goal to not decrease the volume of alcohol has been a big philosophical shift, even for our most seasoned harm reductionists on our team, and is something to bear in mind while we move forward with our discussion today. Just to briefly mention, overall, there are two main types of managed alcohol programs. There's the peer-based and the clinician-initiated models. Peer-led managed alcohol programs are, of course, run by people often with lived experience, versus the clinician-initiated models, which we have, which are better suited to serve individuals who are at high risk of withdrawal complications or have medical complications associated with their alcohol use. Our program falls into the latter category. The majority of our participants have high levels of clinical, functional, and cognitive support needs, often as a result of their longstanding alcohol use disorder. What makes a managed alcohol program unique is that we actually provide measured and regulated doses of beverage alcohol, usually in the form of vodka or beer, to people with severe alcohol use disorder. Excuse me. We do this in a residential setting, and the goal is to help clients achieve a safe level of intoxication to mitigate the harms related to overintoxication and binge drinking. We provide housing, 3 meals a day, activities and clinical and behavioral health services on site. Alcohol is dosed by registered nurses to program participants. Each participant's alcohol dose is personalized to their own need and their own desire. As we have nursing staff on site, we also provide services much like those in permanent supportive housing, such as medication management, chronic disease management, wound care, and care coordination. We do have a closed campus model. So clients are taken out on activities and to appointments with a program escort, and we offer a variety of activities on site. We have been increasing our programming, and even in fact, recently we had a field trip to the Giants game, and our clients ended up on the Jumbotron, and that was just a really, really fun day for everyone. But as I mentioned, we have our clinical and behavioral health services on site, and we provide linkage and care coordination to community resources. And my colleague Bryce will be discussing those in detail later. So I'm sure this is the family medicine folks. I'm sure a lot of people on this webinar are already thinking of clients that they have in their primary care practice and who they can refer to such a program. For our program in particular, the target population includes individuals with severe alcohol use disorder who are experiencing harms due to their alcohol use, but are not motivated for abstinence or have not had success in abstinence-based programs. Our subpopulations of focus at the moment are individuals experiencing homelessness or at risk of or have a history of homelessness, high utilizers of the EMS, emergency department, and acute care services, being a member of the Latinx or Indigenous Mayan populations. We commonly accept referrals from EMS 6, the community paramedic program, community care providers, primary care providers, street medicine, shelter health, nursing services and permanent supportive housing, and the addiction care team at ZSFG. It would be hard to discuss program impact, case studies, and ethics without having an idea of how the program works day to day. When someone is admitted to MAP, we start with an induction period, which is the first 48 to 72 hours. Before going further, I just want to clarify some of our terminology that we use. We use the term SDE, or standard drink equivalent. One SDE is equivalent to 50 cc's of vodka or liquor, 12 ounces of a 5% beer, or 5 ounces of a 12% wine. You can see that we have in purple the SDE chart, and then we dose alcohol based on the traditional CWA score, and also on a new scale that we've been using that we adapted from Canada, the Rapid Alcohol Intoxication Score. With that in mind, when the client arrives, we do a full clinical review of the client to understand if there are any clinical concerns that would complicate the induction, and also ask the client to estimate how many SDEs they use daily. Now, of course, we don't use the terminology, how many SDEs you use daily, but we do have our handy chart here. So if a client says, well, I drink a pint a day, we know that that person is drinking about 8.5 SDEs a day, for example. Once we have the self-report of what the client is drinking each day, they're assigned to a above 10 or below 10 SDE a day protocol. But on average, clients are receiving 1 to 2 SDEs Q2 hours, 1 to 2 SDEs Q2 hours. Prior to dosing, the nurses assess the clients for over-intoxication using the RAISE score and for withdrawal using the CWA score. And then this can help us titrate back or titrate up on someone's alcohol dose. Clients can also ask for additional PRN SDEs during this induction period, provided they are not over-intoxicated by the RAISE score. At the end of the induction period, the total SDEs are calculated and broken up into an individualized dosing schedule. Once the total number of SDEs per day is determined, the dosing schedule is usually about 3 or 4 times a day, but more frequent if needed based on the individual care plan. You can see here, this is a picture of our dosing board. So you can see, for example, the first person here drinks vodka and gets a total of 16 SDEs a day. They get 3 SDEs at 6 a.m., 10 a.m., 2 p.m., 6 p.m., and then 4 at 10 p.m. overnight. And you can also see the range here. We have someone who's getting as many as 16 SDEs a day to someone who is working on tapering and working on other goals who's down to 2 SDEs a day. Even after the induction period and the dosing schedule is set, however, nurses assess the client for over-intoxication prior to all dosing, even for our well-established clients in the program. Clients are allowed to ask for extra and PRN SDEs, and these can be dispensed based on the RAISE score. I do want to acknowledge that once someone is settled into the program and has their dosing schedule, we do find that if someone is asking for an additional PRN, we're also assessing that client to see if they have any needs and to reinforce other coping skills. Because we can also offer medication assisted therapy and counseling to help with those cravings to augment our harm reduction approach. Our target staffing model, I know that there are probably some folks on here who have clients that they've referred, and we are hoping to be able to get our staffing model up to where we can be operating in full capacity soon. But our target staffing model is that we should have 2 RNs on site 16 hours a day for clinical needs, and then 2 behavioral health technicians on site 24/7 for milieu management. We also have a dedicated MAP social worker to provide linkages to community resources, but to also provide the behavioral health assessments and interventions on site, and also to coordinate on-site therapeutic groups and activities. We have clinical staff to support our program. We have a 0.5 NP who manages inductions and dosing changes. And also Tanya, our lead physician, as well as myself as a dedicated nurse manager shared with the Sobering Center. We have a strong partnership with our EMS 6 colleagues for recruitment, engagement, and community follow-up after MAP discharge. And with that, I'm going to pass it along to my colleague, Bryce.
All right, thank you, Alice. So today we're going to talk about behavioral health and milieu management. So let's go ahead and go to the next slide. So when we think about behavioral health in the context of MAP, we can identify 3 different phases that we support our clients, and that includes assessment, intervention, and follow-up. Within assessments, our staff conduct a number of different assessments in order to identify the client's level of care. Typically, we use a tool called the ASAM level of care that identifies 6 different dimensions that are most impacted by a client's substance use disorder. And that way we know and can have some guidance in terms of if the client requires a higher level of care than what we can offer, if they maybe need a more acute level of care to manage suicidality, or if they need to be referred to a psychiatrist in order to have medications for an auditory hallucination. That way we can link them and have some guidance in terms of where exactly we need to intervene in, and what areas, what domains are most critical to intervene on. We also work with our clients to identify goals of care. So while they're with us, typically many of our clients need referrals for financial assistance, including general assistance and Social Security. They may need access to CalFresh and to get the Medi-Cal benefits reinstated. So when we meet with our clients, we identify what exactly those referrals, what exactly are needed, and then begin working with them on linking them. And then as a requirement for our program to receive on-site social work services, we also have to establish an alcohol use disorder diagnosis. Once those conditions are met, then we move into the intervention phase. And that includes, as I mentioned before, identifying client documents that are in need. That can be an identification, a passport, Social Security card, and securing some kind of income. A number of our clients, before they make it to MAP, they're not linked with primary care, or if they are linked with primary care, they're not attending on a regular basis. So we begin to coordinate with the client's primary care provider, or help them find a primary care provider and link them to those services to begin establishing care. And again, consistent with what Alice was sharing, the goal is to move away from a model of providing emergency care to providing more long-term preventative care, and then sort of transitioning to that model. We also assist our clients with engaging with psychiatric care, as well as wellness activities. On site, we offer evidence-based treatments, and that can take the form of individual therapy as well as harm reduction groups. And then we also offer wellness activities, including walks, stretching, art, and social cultural activities. We find that many of our clients, once they begin settling into the day-to-day within MAP, they begin craving activities and wanting to sort of express themselves in different ways. So we actually connect them to different community-based organizations that assist us with conducting art groups and poetry groups, and just kind of help them explore ways that they can express themselves. We also then transition into the follow-up phase, which includes regular client check-ins. That can be in the form of just reassessing what their goals are, reassessing that their needs are being met, that they're still at the appropriate level of care. And we also, as part of our contract, gather information in the form of a yearly satisfaction survey. So to identify how we can adjust our program to better meet their needs and to better support them as their lives change. Next slide, please. So maybe we can go into some examples of social and cultural activities within a MAP program. So you see here a picture of our ofrenda from Dia de los Muertos from last year. These kind of activities we have found have been very important to the clients in being able to express themselves and express their own culture, their cultural identity. So we have staff that help assemble these different sort of ways that they can express themselves and kind of build community on site. We assist our clients with developing life skills through life skills groups, and that could take the form of helping clients learn how to do various kinds of food prep, or managing their benefits independently, or managing their finances independently, all of which are important skills, whether or not they're living on site at managed alcohol program or decide to transition out and try independent living. We also find that as I mentioned earlier, a number of our clients express themselves through writing. We have one client who has been working on a series of comic books and asks to go to regular visits to the library to find inspiration. We've had a client in the past that participated in a weekly poetry group and had the goal of getting his poems published, kind of written into an anthology and published. And so as we sort of noticed that as clients, as their alcohol needs are being met, and as they receive 3 meals a day and they're able to get those sort of basic needs met, then the sort of big picture goals, the sort of goals that they would like to achieve sort of become more into focus. And when we think about social and cultural activities, our job as social workers is really to help them connect to those activities, discover those activities, and help them achieve those goals. We also find that a lot of our clients want to engage in exercise and movement, really just to go on daily walks and to get out of the sort of confines of the hotel. And that's something that our program does offer as well. Next slide, please. So here we'll talk about managing the milieu a little bit. We do encounter some issues in our program that sort of deal with some of these topics, like clients acquiring outside alcohol and sharing alcohol. I would say that within an average week, this happens maybe about once a week or so, both finding and acquiring outside alcohol and sharing alcohol between clients. I'll talk about how we address that in the next slide, but just kind of keep that one in mind, that that's something that we often deal with. Marijuana consumption is something that's fairly common in our site. We do not have a policy that that says that clients are not allowed to smoke marijuana. They are allowed to smoke or to consume marijuana on site. But that is something that as health providers that we try to monitor and kind of watch out for any sort of effects that it may have upon their health or upon their how they interact with other people, you know, whether or not it's causing a problem within the milieu, or there's any sort of interpersonal issues or anything that might put them in terms of that might be damaging to their health in terms of sort of loss of coordination or loss of motor coordination that might result in a fall or any kind of incident like that. So we do monitor for marijuana consumption. Acute psychiatric episodes is also something that we monitor. Just kind of anecdotally, we notice that oftentimes when clients are on a stable dose within MAP, we find that for those that are maybe not linked to psychiatric care, that there's a lot of there's an untreated mental health component that was previously being addressed through street-based binge drinking. And we find that when clients are on a stable dose of alcohol, that oftentimes those symptoms can come up and clients may need some support with dealing with that. So we try to link them with psychiatric care and try to assist them with linkage to regular therapy and to other wellness activities to better manage that. As that comes up on site, we do have a client agreement where we support the client by identifying, like, you know, hey, there's a moment that, you know, you may have postured towards another person, and just sort of support them with identifying behaviors that they may want to engage in that can help cope with whatever's going on, or different outlets that they may take so that they're not posturing at another person. Ways that we can support them with making better decisions that decreases the frequency of these sort of incidents. So when we think of responding to milieu disruptions, we have a few different tools. I mentioned the client admission agreement. It's something that all of our clients sign when they begin with us, and it just outlines the program rules, real basic stuff like that you agree not to share alcohol or acquire outside alcohol, that there's no violence on site, no threats of violence, you know, no racial or sexist slurs towards other people. We also have a sharing alcohol agreement and a behavioral agreement, and they both outline sort of steps that can be taken where the behavioral health team and the nursing team intervenes to support the clients. And each step there's 4 different steps, with the 4th one resulting in discharge from the program. But it's sort of a tool that we use to help guide and support the client with identifying what kind of interventions they think they need and what we would recommend as the behavioral health team to best support them to you know, get through this episode. So for a client that maybe postures or makes threats at another client, we might recommend that you know, we connect them with an anger management group, and that we maybe encourage them to start going on regular walks. That way they can kind of get out and enjoy some fresh air, just whatever best meets their needs. And then they also have a chance to identify what their needs are and to advocate for an intervention that they believe best fits their needs. So really, in terms of building a healthy milieu, we're looking for activities for our clients to engage in and to participate in regularly. We're looking for clients to build trust in the staff and trust in each other. And it does require some good, strong de-escalation skills in the event of any sort of behavioral incidents. Next slide. So outside alcohol is, like I mentioned before, it's something that we deal with often. And what I mean by that is that clients are able to somehow get alcohol from off-site, or sometimes they may store their alcohol that was provided to them in a separate bottle, and then go back and ask for their next next SDEs, and then sort of begin kind of hoarding their alcohol. So ways that we try to address this is that first, we're closed program design, and by that we mean that clients are not allowed to leave the facility without a staff escort. We ask that our clients be on site for some amount of time prior to the alcohol being dispensed. So if a client has an appointment that may interfere with their dosing schedule, then we sort of look at, working with them to adjust the dosing schedule so that it best meets their needs and so that they're not getting their alcohol, sort of within too close of interval of each other. We also, the RNs will assess for intoxication prior to dispensing alcohol, just to ensure that they're not receiving more alcohol when they're already intoxicated. And it also gives us a clue that if somebody is showing up intoxicated, that maybe there's something missing. Maybe they were able to sort of sneak off site and go buy a pint somewhere. This is sort of a new point that we've been doing fairly recently, but we've been trying to limit dispensed alcohol to less than 3 SDEs. And sort of reason being is that at that point, we're looking at what's that, about 3/4 of half of a pint. So it's quite a bit we've discovered for a client to be receiving at one time. And again, just sort of anecdotally, we noticed that when clients have more alcohol at once, they're more likely to share amongst each other. And so the clients that maybe have lower tolerance, if they're getting more from their buddy that's getting 3 SDEs, then they're more likely to get intoxicated. So we try to limit that and provide no more than two SDEs at one point. And then the rules sort of link repeated use to repeated outside alcohol with discharge. So like I mentioned before, we work with them on supporting their behavioral needs, but we do keep in mind that at a certain point, it becomes so disruptive to the milieu that we have to account for everyone's overall health, and that in that instance, discharging of a client that's providing alcohol to others and disrupting the milieu in that way is ultimately, it's better for everybody if that client then gets discharged and then referred to another service, be it shelter, navigation center, or to their SRO. And then we do have, we've kind of been exploring the rules and protocols that prevent storing of outside alcohol on site. One thing that we do that has been very helpful is each of our clients have a different colored water bottle that they receive their alcohol doses in. And that just helps us being able to monitor with, to kind of notice when people are trading their bottles around and this person's supposed to have this color water bottle, so why are they holding, the red one when they should be holding the green one? So that just kind of helps us monitor with making sure the alcohol isn't being shared. Next slide. So we'll get into a little bit about participant demographics and program impact, sorry. Next slide. So this slide sort of addresses some of the key metrics, some of the outcomes that we've identified over the course of managed alcohol. Since the program has been established in 2020, we've had 40 unique clients enrolled with 56 discrete episodes. So sometimes we get clients that had previously been discharged, but then decide that they want to come back. Maybe they need to stabilize again before going into a program. Maybe they, had a change of mind and really thought that MAP was really beneficial for them. And they do have quite a bit more difficulty managing alcohol independently. So they want to come back and work with us again. So that's why sometimes we get people that return to us. The average length of stay for a discharge client is 144 days, and the average length of stay for an enrolled client is 246 days. 78% of MAP participants are on medication-assisted treatment during and after their MAP stay. And then we have some information about the clients that we work with in terms of their housing status, the significant majority of them being unsheltered prior to a MAP referral. We find that our clients have a median age of 55 with an age range anywhere between 29 and 76. 88% of our clients are male identified, and 78% of our clients preferred speaking in English. And then here we kind of see the racial and ethnic breakdown of our clients, 45% of them being white, 33% Latinx, 15% African American, 5% American Indian, Alaska Native, and 3% Asian. Preliminary outcomes that we've identified, again, since 2020, we've noted a fourfold decrease in ED utilization, twofold decrease in EMS activation, and twofold decrease in hospitalizations. Many of our participants report improved sense of health, hope, safety, and stability. Next slide. This slide expands on the previous notes from the previous slide. How clients report MAP has impacted their lives. We've received quite a bit of positive feedback about MAP. Clients have stated that made comments such as, right now I would not do well there. I'm speaking about a non-MAP permanent supportive housing. I've never felt more stable than I do now. I do not want to give that up. And if I were not here at Site 42, which is the designation for managed alcohol program, I would already be dead. I am sure of it. A newly enrolled client struggling to remain in the program stated, "These 3 weeks in MAP are the best I have felt in a long time." And a MAP client returning after self-discharged, "Wild horses couldn't drag me away." We find that many of our clients find a sense of community and pride in having their own space and have felt support from on-site staff. And I can't emphasize the sense of community enough, that many of our clients do feel like they have friendships for the first time, that they have connections and built something bigger than their individual self within the context of MAP. Next slide, please. So this breaks down some of the information about a client's ED, EMS, and sobering center utilization prior to managed alcohol and during managed alcohol. So some background on the client. This is a 58-year-old male with severe AUD, diabetes, delusional parasitosis, and ambivalence about MAP program. During his 3rd and 4th month at MAP, he self-discharged and then returned to the program, sort of went into the cycle of discharging and coming back, discharging and coming back 3 times. During his time in MAP, he was linked to primary care, psychiatric care, and intensive case management. His current goals are working towards more community independence, including volunteering at a church where he feels connected. And in this graph, we can see the six months prior to admittance at MAP, and then the 6 months after enrollment with MAP. And particularly month 2 and month 1 before MAP, I find staggering. 28 EMS transports in the 2 months prior to joining MAP, 10 sobering center visits, and 19 ED visits with total hospital stays of 8. And the month prior to joining MAP, 14 EMS transports, 17 sobering center visits, 10 ED visits, and 15 total hospital days. And then when we look at the days, the months after MAP, there were nothing for the first month, nothing for the second month. Month 3 and 4 were the months that he was in and out. So we do see some elevations there. And then after re-enrollment with MAP, nothing for months 5 and 6. Next slide, please. This is another MAP client, a 37-year-old male with severe AUD, psychotic disorder, NOS, and he enrolled in MAP after repeated engagement efforts. And this is a similar setup, the 6 months prior to admittance to MAP and the 6 months after. And we see that 3rd month is really elevated with the 3 months prior to joining MAP. We see 24 EMS transports, 34 sobering center visits, 6 ED visits, and 3 total hospital stays. The first month after after MAP and really the subsequent months after MAP, we see a significant decrease in total hospital stays, ED visits, sobering center visits, and EMS transports. The most elevated being that third month of 8 total hospital stays. That's for after admittance to MAP. So the information that we gather, just sort of based on these metrics, we see that managed alcohol program has been effective in decreasing total hospital stays, ED visits, sobering center visits, and EMS transports. And next slide. So for this part, I'm going to hand the baton off to Dr. Tanya Majumdar. Thank you.
Hi, everyone. So as our program evolved from a short-term isolation and quarantine or shelter-in-place model during COVID to a longer-term continuity program, a number of recurrent ethical questions began surfacing given the nature of the work, the high acuity population we serve, as Bryce has just talked about, and the long-term impacts of ongoing alcohol use. Next slide. In general, these ethical questions have fallen into...
Sorry to interrupt. I don't see the slides anymore.
Tanya, I thought you were putting your own slides up. I can start sharing again if you need me to.
Could you start sharing again? I think I was having some trouble earlier.
Okay, sorry. You should be set.
Thank you. Thank you, Alice. Next slide. So in general, these ethical questions have fallen into one of 3 main categories. The acute harm of MAP enrollment. Can starting or continuing MAP cause harm in the short term? The second is the long-term harms of MAP. What does it mean to have continued participation in the face of progressive liver disease, cognitive or functional impairment in the setting of regular prolonged regulated alcohol access? And the third is that we really take the ethical tenet of patient autonomy as our primary ethical tenet, which we'll talk about a little later. And what does it mean to serve MAP clients with cognitive impairment or a lack of acknowledgement that alcohol is actively worsening their health? Next slide. So we're going to talk about a case presentation, Mr. G, and start by talking about Mr. G before MAP. So Mr. G is a 38-year-old man with alcohol use disorder and psychotic disorder. Prior to MAP on the street, he had declined shelter because of visual hallucinations of, quote, giant bugs crawling out of people that were, quote, worse in shelters. They aren't clean and the bugs are everywhere. He had over 36 ER visits or admissions from September 2021 when he initially arrived in San Francisco to June 2022 when he was admitted to MAP. At one point, his blood alcohol content was 863, but it was more usually in the high 300s to 600s. There were multiple tries to admit him to MAP, and he finally stuck in June 2022 after agreeing to start psych meds in February 2022, and after we gave him some offers to rest at MAP to help him heal a sprained ankle. Next slide. As you can see, for 4 months on the street in San Francisco before he came into MAP, you can see all these ED visits, and next slide. At 11 months in MAP, he's had a significant decline in the number of ED visits and admissions. So a really huge change. Next slide. But he continues to have bouts of alcoholic pancreatitis, 6 that we're aware of, and he is not interested in decreasing his alcohol consumption further or in abstinence. He also expresses doubt about alcohol being the cause of his medical issues. He said things like, quote, they told me I was constipated, or quote, it's my back that hurts and that's not related, or quote, the doctor said even if I stopped drinking, I might still have pain, so I don't think that's what the problem is. Next slide. So as we process through these difficult questions, our team has relied heavily on a partnership with the San Francisco General Hospital ethics team. Through a series of ethics consults, our team has developed a framework for guiding ethical discussions that we use to think through challenging questions. This framework relies heavily on the core tenets of medical ethics, placing primacy on patient autonomy while balancing that autonomy with our team's commitment to do as little harm as possible. We have the core tenets of medical ethics up on the slide. We also think a lot about non-maleficence, the idea of do no harm. And we also think about distributive justice. What does it mean both for MAP as a limited resource, and what does it mean for a patient taking up space at MAP who might be able to be somewhere else, but also what does it emergency rooms, hospitals, and EMS services are also limited resources. And if our patients are in the community, are they taking resources away from other people? And we also think a lot about the principles of palliative care in our work. We understand that our participants' ongoing severe alcohol use disorder in the context of the desire to continue to consume alcohol can be a life-threatening and potentially life-limiting medical condition. Some of the principles of palliative care that we really think about in our work include understanding severe alcohol use as a life-limiting medical condition, respecting patient autonomy, placing patient preference above clinician preference, and providing compassionate care. For us, almost always considering the basic questions, which are, for us, does the participant think MAP is the best option for them right now? Does the participant envision a life without drinking now or in the future? And does the team think that the client is safer in MAP than in an alternative situation, which is almost always continuing to drink in the community without support, has helped us to forge a path forward? It's always a really helpful reminder for us that the alternative to MAP is not abstinence. Next slide. So for Mr. G, some of the major ethical dilemma that we were struggling with was, how do we think about a person who is clearly benefiting in many ways from MAP and suffering acute and chronic harms from it, and may not fully accept or believe in alcohol as a cause of that harm? So we really thought for him about autonomy, beneficence, and non-maleficence. Next slide. So where we landed, autonomy is prioritized in the US or the global north. So for Mr. G, we asked him two of our basic questions. If you had to choose a longer life with no alcohol or a shorter life with alcohol, which would you choose? And he said he would choose a shorter life with alcohol. The second question was, can you envision a life worth living that did not involve alcohol? And he said no. Because of MAP and his psych meds, he's in a space where he can engage about his wishes at all. We integrated a palliative and ethics approach and reminded ourselves that MAP versus abstinence is not the decision, and decided to allow him to continue to be in MAP and receive alcohol. Next slide. And so lastly, we wanted to briefly talk, before we broke for questions, about a few ways that MAP can partner with inpatient services. Next slide. So while one of the benefits of MAP is that it helps to decrease alcohol or acute care service needs, our patients still do end up in the ED and on inpatient teams. If you're taking care of a patient enrolled in MAP, we really appreciate your help, and we want to think about partnering across all these different levels of care. Some of our thoughts include asking your patients about their goal and plan for alcohol use after the hospitalization. For our patients, we may jump in or ask for an ACT consult if you're at San Francisco General, but these are super helpful discussions for the primary team to take on. Our second point is a little bit contrarian. We ask that you use benzos judiciously. The subjective nature of the CWA scores, we're all aware, results often for our patients in higher benzo equivalents than the SCEs that they're getting at MAP. And third, feel free, now that you know about MAP, to discuss the program with potential participants. Community referral partners have commented that talking about MAP as an option has been a nice on-ramp to talk about the discussion of other harm reduction approaches to alcohol use disorder. And then finally, please feel free to refer to patients. Our email is below. Next slide. finally, we wanted to acknowledge some of our partners in this work. Supporting our participants is not limited to the services provided by MAP program staff. Our team works really closely with a number of community partners, including our local community paramedic program, EMS6, that you've heard about a few times, who act as a liaison to many of our clients before, during, and after participation in MAP, as well as our street medicine team that provides continuity primary care for many of our participants. I'd also like to highlight that our team has developed close relationships with the San Francisco General Addiction Medicine team, who both refer patients for program enrollment and assist us in facilitating patient-centered care when our participants are admitted to the hospital. And then finally, we want to make sure we acknowledge the visionary leaders at the San Francisco Department of Public Health who have been in support of this program model and harm reduction programming in general that bring services and dignity to high-risk marginalized populations. Next slide. And you can skip. Yeah, these are some of our references. And then thank you. And we have a few minutes. We'd love to take any questions that you have.
Tanya, Bryce, Alice, thank you so much for this moving presentation about such an important program, so patient-centered, really shows how deeply healing this could be once folks are able to receive the support. It was very illuminating hearing about the ethical considerations as well. And then the personal stories, the poem around being sweeter than a honeybee is particularly poignant. So thank you so much. We are coming to the end of our time. And so I think we won't have a lot of time for questions, unfortunately, but I wanted to see if you had any final thoughts that you would like to leave with us. I certainly am taking home how to make referrals and then the note about the use of benzodiazepines as well. Very, very enlightening. Any final comments before we close?
No, I just really appreciate the interest and the opportunity to present on this. It's a new program. We're growing it. It's really exciting. And we're really looking forward to partnering with all of our community partners, including everyone on this webinar in this work.
We're all partners in this work. Thank you so much. Have a great afternoon.